we're familiar with.
Yeah.
We're familiar with the mix, and I had asked him about it, and he said he actually knew the guy who came up with it. So that's me. So if you guys want to start, we can just, this is, I didn't know if it was going to be formal, informal, so I kind of just took bits out of a PowerPoint that I've been giving on opiate-free anesthesia for last several years. So we can start out with the first slide. So just go over, objectives is to review pain physiology, just a basic overview, because in order to treat pain, we need to understand pain. So I like to go over, exactly where the medications we'll be using in opiate-free anesthesia work on, evaluate, this was from another lecture that I gave on using, I gave on a substance abuse group on people who are in recovery, actually, who are looking at alternatives to opiates for pain management. So we're not going to go through continuing Suboxone and buprenorphine, but that's where that came from. We're going to look over the different medications that we use in opiate-free anesthesia. And hopefully you guys will learn some ways to decrease or abstain from the use of opiates in the perioperative arena. Next slide. So anatomy of pain. Let's just going over your two different types of nociceptive fibers, which are A delta and C fibers. A delta fibers, as we know, are lightly myelinated and smaller diameter. They're going to respond to mechanical and thermal stimuli. They're going to give you that rapid, sharp pain. So that's what the patients are feeling when the surgeon makes their incision. If they respond to an incision, that's going to be from the A delta fibers. And those are very localized sensations. Next. Your C fibers are the unmyelinated, smallest fibers. They're going to transmit slow and diffuse dull pain. So that's pain that comes later on after an injury, or tourniquet pain is a prime example of a C fiber activation. C fibers are more of your dull pain that you're going to have. So the substances released from your nociceptive fibers, A delta is going to release glutamate, and C fibers will release substance P and glutamate. Glutamate is your key excitatory neurotransmitter in the somatosensory system. It activates AMPA and NMDA receptors, NMDA receptors being very important to us anesthesia providers. I like to go over the marriage, I guess you could say, of the NMDA and magnesium ion. So then the NMDA receptor is actually inactive due to a magnesium ion plug. And as that NMDA receptor is activated by glutamate, it'll cause a constant depolarization, and then that magnesium ion will be released, and that opens up a calcium ion channel, and that allows the influx of calcium. Now, when calcium gets into the cell, it increases nitric oxide production, which causes more release of glutamate from the presynaptic neuron. So you kind of get in this positive feedback loop. So it's important that we block the NMDA receptor and increase our extracellular concentration of magnesium ions. Substance P is your key excitatory neuropeptide in the somatosensory system. It's released by C fibers primarily and activates neurokinin receptors in lamina 1 and lamina 2, your substantia gelatinosa. So the 4 stages of pain being transduction, that's the stimulus converted to electrical signal. Then you have transmission. That converted electrical signal is conducted through the nervous system. Then you'll go through modulation. That's alteration of the signal along the pain transmission pathway. The descending inhibitory pathway is where endogenous opiates would be released during modulation. And then perception is the final stage, and that's where we have that subjective sensation of pain. So when there's an initial injury to your tissue, you get what's called peripheral sensitization. And that's going to cause the release of bradykinin, prostaglandin, serotonin, cytokines, and hydrogen ions. This sensitizing soup, as I like to call it, it will directly induce a pain transmission and increase the excitability of nociceptors and decrease pain threshold. So really one of the goals with OFA is to decrease this peripheral sensitization from happening. And so you'll see later on in some of the medications that we give is working to decrease that sensitizing soup. So the body doesn't really have a chance to amp up the pain transmission. So with opiates, you can get what's called opiate-induced hyperalgesia. You can go. So this is just a slide showing how opiates work on the presynaptic neuron. It's going to inhibit so when the mu receptor is activated, it inhibits the influx of calcium, which would, if calcium came into the neuron, would cause a release of substance P. So opiates presynaptically block when activate the mu receptor, it closes off that calcium channel. They also work postsynaptically and on the mu receptor, and that helps to decrease the activation of the NMDA receptor and keep it from depolarizing. So opiates can work on the presynaptic and the postsynaptic neurons. With opiate-induced hyperalgesia, we enter a state of nociceptive sensitization caused by exposure to opiates. So they've done studies in rats and mice, and what they see is when you give a rat or a mouse what they saw fentanyl, the more fentanyl that they gave, they actually became more sensitized to the pain. They'd have more reaction pulling away from a painful stimuli than when they first got an opiate. Now, the opiates can have this effect, and it's really based on the potency of the opiate that's giving. So remifentanil is your most potent opiate that you're going to give. And you have a lot of opiate-induced hyperalgesia with that. You'll see patients who get remifentanil require more opiates in recovery than those who didn't get it. And it's not more because of the remifentanil is wearing off and they have no opiate on board. It's actually causing an increase in the sensitization of pain. So they're going to even require more opiates in recovery than if they didn't even get the remifentanil. You can see it in fentanyl, sufentanil. Your morphine and dilaudid aren't going to have as much of effect, but with opiate-induced hyperalgesia, you can also see it in patients who are on chronic pain medications. So, and that can lead to like allodynia, where just any type of a pressure or a non-painful stimuli can cause pain. So there's some different theories of what causes opiate-induced hyperalgesia. The main one being a central glutamatergic system. And then you have the spinal dynorphins, which is kind of like the body reacting against itself. The descending inhibitory pathways can actually increase opiate-induced hyperalgesia. You're going to have some genetic influences, and that's going to be your second most common causes of it. So glutamate plays a central role in the development of opiate-induced hyperalgesia because opiates can activate a stimulating G protein, which increases the amount of glutamate release. So it causes the NMDA receptor to increase the nitric oxide production, and it will decrease the postsynaptic mu-opioid receptors function. So the patients aren't going to be getting that good of effect from their opiates either. In inhibition of we go back to using that glutamate receptor. If you can block the NMDA receptor before you give an opiate, you actually can prevent or decrease the incidence of opiate-induced hyperalgesia. And that's where ketamine comes into play in ketamine clinics of patients who are on chronic opiates. They've had great success of going to a ketamine clinic, getting infusions of ketamine, and then still staying on their same regimen of opiates, but having a better effect, or the opiates being more effective. So I try to encourage, if you're going to use an opiate, give ketamine before you give it or with it. Methadone, which is if I was going to use any opiate, that's what I would prefer to use. It has mu agonist properties and an NMDA antagonist properties. So that would be, in my point of view, one of the better opiates if you're going to use one. And they're starting to use it, and I know a lot of spine surgery, stuff like that. Next. The genetic changes would be at the COMT, at the activity of COMT, and that's the substitution of the amino acid valine for methionine, and that decreases the breakdown of dopamine and noradrenaline by up to 400%. And increased dopamine and noradrenaline levels increase pain sensitivity, and that's just your sympathetic nervous system is ramped up, and that's going to change how your body reacts to pain also. So opiate-free anesthesia. So what is opiate-free anesthesia? This is where I like to kind of tell the difference of opiate-free anesthesia versus opiate-free analgesia, okay? Opiate-free anesthesia is just the absence of using a mu receptor or mu receptor agonist in the operating room. Opiate-free analgesia is kind of what we aim for if we're going to use nerve blocks in the operating arena, or if we're going to continue using these meds post-operatively. With opiate-free anesthesia, it doesn't mean that a patient's not going to require an opiate post-operatively. Just as if you did a balanced anesthetic and you gave opiates in the operating room, you're not going to expect them not to require any opiates in recovery. So, but with patients who have opiate-free anesthesia, we're looking at using an opiate as the last line of defense instead of the first line of defense. And we're using this by, working through systematically the different causes of pain. So why use opiates anyways? Sorry, I got everyone texting me. Why use opiates? It's because they do have a safe intraoperative profile. They have minimal cardiac depression. There's not really a toxic dose for opiates. As long as you can ventilate for your patient, you're really not going to kill them with the opiates. They're great for, blunting pain transmission, and they're thought to provide a basis of postoperative pain control. I'm not one to say that opiates don't have their place. They're very effective for certain types of pain management, but they shouldn't be used as the first line of defense. So why not to use them? Well, if you're giving them to a patient who's not intubated or in recovery, they could cause respiratory depression. You have a higher incidence of nausea, vomiting, pruritus, urinary retention. Opiates suppress the immune response, primarily suppression of natural killer cells. So giving them, and some cancer surgeries, some studies have shown a higher reoccurrence of cancer, especially breast cancer, postoperatively, when compared with those who didn't get an opiate. They can cause a cognitive sleep dysfunction. This is really important in your elderly population. They're already suffering, from constipation issues, sleep issues, and then you add opiates on top of it, you can really mess up an elderly person's sleep cycle. You have an increased risk for addiction postoperatively. There's a strong correlation to the amount of opiates that a patient would get intraoperatively. Correlates with how much opiates they're going to have to take post-operatively. And then you have the increased risk of chronic pain with opiate administration also. So benefits of opiate-free anesthesia, very stable hemodynamics intraoperatively, decreased risk of respiratory depression. This is what drove me really to going into opiate-free anesthesia, is as a solo anesthesia provider. I needed to make sure that when I left a patient in recovery, that their pain was well controlled and the risk of any respiratory issues were very minimal. If I take a patient to recovery and then I take another patient to the operating room, we have a respiratory issue in the pre-op or in the recovery, there's nobody else out there to help that patient. So that was one of the reasons I looked at trying to decrease the use of opiates in my anesthetic. You have prevention of chronic pain. And that goes along with lines of using ketamine with your anesthetic and more regional anesthesia techniques. You'll have an increased effectiveness of opiates administered post-operatively. That's one thing that my PACU nurses quickly realized was, you know, a gallbladder was getting 1-2 milligrams of dilaudid in recovery. And that was on top of me giving 3 to 5 cc's of fentanyl during the case and 1 to 2 of dilaudid at the end. Because before opiate-free anesthesia, I was pretty heavy-handed. I aimed for a tidal volume of 900 and a respiratory rate of 8 at the end of the case. So I wasn't afraid of opiates. I thought they were a good thing for my patient, but ignorance was bliss on that front. So, and when we started using opiate-free techniques, we quickly decreased the amount of opiates that we're using. We went from 1 to 2 milligrams to less than 1 milligram. We now only have 0.5 milligram syringes of dilaudid, and my nurses say they may use it a couple of times a month. Our pharmacy quickly realized that we were wasting so much dilaudid that, you know, we had 2 milligram syringes, and they came by and after a couple of months of me doing OFA, switched them out to 1 milligram syringes, and then quickly to a 0.5 milligram per ml syringes. You're going to have a decreased incidence of nausea, vomiting, pruritus, constipation, urinary retention, immune suppression, cognitive sleep dysfunction. My nurses joke that they're not real PACU nurses anymore because they rarely deal with nausea, vomiting issues. Patients are pretty alert afterwards. Rigors and recovery is pretty much gone with me using dexmedetomidine and magnesium in the operating room. So really their job is just to get the patients awake, stimulated, and out the door. They don't have to deal with oral airways because the patients aren't obtunded from heavy opiates in the operating room. So it makes the whole peri-operative experience a lot better for the patient. Next. So when we're doing opiate-free anesthesia, like I mentioned before, we want to manage peripheral sensitization and central sensitization. The goal is to prevent opiate-induced hyperalgesia, so our opiates are going to be more effective if needed in recovery. When you do opiate-free anesthesia, it's very important to make sure that you're using a weight-based dosing on your drugs. You don't want to give too much dexmedetomidine. You don't want to give too much magnesium, too much ketamine, because that's going to cause the patient to be sleepy in recovery. You could have some blood pressure issues. So what I aim for is ideal body weight for all of my medications. If the patients are, you know, morbidly obese, I'll look at using an adjusted body weight. I set the standard at if the patient's actual body weight is ideal body weight plus 30%. If their actual is greater than that, then I'll use an adjusted body weight. But I really try to stay with just using ideal body weight, especially when I'm running my mix. I can just titrate it up if needed. And I can tell you 95% of the time, I never change my drip rate. Next. So with peripheral sensitization, it's an inflammatory process caused by tissue injury. Kind of went over this. You know, you're having your inflammatory mediators release, decreased pain threshold of the C and A delta fibers, and increased frequency and amplitude of pain signal to the spinal cord. So ways to decrease peripheral sensitization is using local anesthetics. So you can do a neuroaxial block, you know, spinal, an epidural. You can do different types of peripheral nerve blocks, your extremity blocks, your truncal blocks. You know, we do a lot of interfascial plane blocks, quadratus lumborum blocks, tap blocks, erector spinae blocks, things like that. If you can't do any blocks, using a lidocaine infusion is very helpful. Personally, if I block everything except for a colonoscopy or cataract, and I run a lidocaine infusion when I've given a nerve block. I'll do the nerve block in pre-op or in before incision, and I still run the lidocaine infusion. You're running at a very low dose of 2 milligrams per kilogram per hour. You're using ideal body weight. You're not near toxic dosages, and by the time the local anesthetic from your block is being reabsorbed, that lidocaine infusion has been terminated, and your patient's metabolized the lidocaine. You can use steroids, Decadron, and that says Toradol and Celebrex, and hopefully in the future, a cannabinoid treatment. So lidocaine is anti-inflammatory, and it decreases, it's a prostaglandin inhibitor, useful in abdominal and urological procedures. They say, you know, I got to put that avoid use with a peripheral nerve block, but from anecdotal evidence of doing this for almost 6 years, I haven't had one last issue, and I'm the only anesthesia provider, you know, at work. So if an issue happens, I have to address it. Initially, the initial bolus, 1.5 to 2 milligrams per kilo, I give that on induction. And then I run the maintenance rate at 2 milligrams per kilogram per hour. And then if you're able to, if you can run it post-operatively on the floor, some places will do that around 1.33, you know, 1 to 2 milligrams per kilogram per hour. You can just continue it at that. Decadron is a glucocorticoid steroid, inhibits the production of prostaglandins, bradykinin. If you're going to use it in patients with diabetes, just let them be aware that if they're on insulin, you know, for 24 hours, they could have an increase in their blood glucose levels. But a lot of diabetic patients are going to have an increased blood glucose level anyways because of the stress of surgery. So I'll still give Decadron to my diabetics. I may decrease the dose, maybe 4 to 6 milligrams. You know, some surgeons will say that it impairs wound healing. The data just doesn't support that. I give Decadron in my nerve blocks, and I'll give it intravenously after induction. And usually that range, usually it's about 10 milligrams that I'm going to be giving to patients. Toradol inhibits production of prostaglandins, bradykinin, histamine. It's about as equipotent to morphine, 10 milligrams. If you're giving it to an elderly patient, you know, you want to, anyone over 65, no more than 15 milligrams. If they have an elevated creatinine level, I don't give it to them. And also be cognizant if they're on a like Plavix or some type of platelet inhibiting medication, you may want to hold off on that. For me, I give 15 milligrams at induction, and then I'll give the other 15 milligrams at the end. There's studies out there that support that 15 milligrams is as effective as 30 milligrams. It's just the duration of action isn't going to be as long. For my elderly, I'll give 7.5 milligrams at induction, and then 7.5 milligrams at the end of the case. Celebrex is a PO med that you could give preoperatively. You don't want to really give Celebrex and Toradol together. You can kind of choose one or the other. It too is a prostaglandin inhibitor. Decreased risk of bleeding and GI side effects and acute kidney injury with Celebrex. You can start a pre-op and then just continue as post-operatively for 7 days if your surgeon's on board. Celebrex works really well, especially for your orthopedic surgeries. When we're looking to manage central sensitization, we want to decrease the substance B release. So those clonidine and dexmedetomidine are the two medications we're going to look at for that. And then we want to block the NMDA receptor, block the action of glutamate. And for those, we're going to use ketamine, run nitrous oxide, give magnesium, and your gabapentinoids also. Okay, next. So clonidine, everybody knows it as a blood pressure medication, but it's an alpha-2 adrenal receptor agonist, decreases sympathetic outflow from the lower brainstem region, decreases release of norepi at both peripheral and central terminals. The analgesic properties are due to both peripheral and central alpha-2 agonism. And by decreasing that norepinephrine release, you're keeping the body from being ramped up by the pain signals also. The peripheral analgesia is blocking of the pain transmission conducted through C fibers, a result of interaction with the inhibitory G-coupled proteins. The CNS analgesia is going to be activation of alpha-2 receptors in the dorsal horn and decreased release of substance P and norepi. And then the activation of the alpha-2 receptors in the locus coeruleus is what's going to give you your supraspinal analgesia, but also more importantly, the sedation. And that comes more into effect with the dexmedetomidine when you use that. Next slide. So, with clonidine and dexmedetomidine, be aware of using in patients with a bradyarrhythmia, those who are afterload dependent, so if they have severe aortic stenosis, but there's also actually been people who've been using dexmedetomidine and ketamine for people with severe AS and having good results. Be aware of coronary artery disease due to hypotension. That's more with clonidine. The clonidine has a very long half-life, so once you give it, you own that for about 12 hours. Next slide. So if you're going to use clonidine, you can give PO 3 to 5 mics per kilo. Give it 1 to 2 hours. The bioavailability is very wide on this, 75 to 95%. If you can get the IV, it's going to say for epidural use only. You can give it intravenously. You give 1.5 mics per kilo at induction. And then if they're having a sympathetic response after incision, you can start working in another 0.5 to 1.5 mics per kilo. You don't want to give over a total dose of 3 mics per kilo because you're just going to be getting into more of a higher side effect profile. And like I said before, clonidine has a very long half-life, so once you give it, you own it. That's why I prefer to use dexmedetomidine. When I first started doing opiate-free anesthesia, Precedex, dexmedetomidine was still proprietary, so it was very expensive. Now, dexmedetomidine, if you have the smaller vials, is cheaper than the big vials of clonidine IV formulation. So I prefer to use dexmedetomidine. Mechanism of action is going to be the same as clonidine. Little less side effect profile. When you give dexmedetomidine bolus dosage, you might get some bradycardia and hypertension. Those are kind of short-lived. And then you can get a little bit of hypotension with dexmedetomidine, but the analgesic effects from dexmedetomidine are far superior than clonidine. And then another benefit of dexmedetomidine is the anxiolytic effects. So I don't give Versed anymore. I haven't given Versed regularly in my anesthetic probably for the last 3-4 years since dexmedetomidine became easier to obtain. If you give Versed with dexmedetomidine, you're definitely going to have an increased sedation effect postoperatively. If you give, the beauty of dexmedetomidine is you can give 5 to 10 mics in pre-op when you go see your patient, even before the surgeons came to see the patient. They're going to have some anxiolysis, and it doesn't cause any amnesia. So when the surgeon comes to speak with the patient's going to remember everything that the surgeon said to him. So I find it a lot more useful. And so when I go to see my patients, I pre-op them, fill out everything, have them sign consent, put a pulse ox on them, and I'll give them 5 to 10 micrograms and then go about my business of getting stuff ready. When I'm taking the patient back, I'll give another cc, another 10 micrograms. And I make up when I say a cc, I take a 10 ml syringe and just squirt out a ml out of it. So you got 9 mLs, and then I just put in another ml of dexmedetomidine in there, 100 micrograms, and I'll make a 10 ml or 10 mics per ml syringe for you, and you can use that your whole case. And if you want to use the McLottMix, you can just squirt it into the solution also. So just like with clonidine, be aware if they have a bradyarrhythmia, heart block, severe ventricular dysfunction, hypovolemic patients because of, it can cause some slow heart rates. Diabetes, I really haven't seen any issues with that. There was concern that you could, cause some autonomic disturbances. we get tons of diabetic patients in the mountains, and I haven't had any type of issues with that. With the elderly, actually, it's good. Dexmedetomidine is good for them. It actually protects their brain against postoperative cognitive dysfunction. So the patients are going to be more clear-headed when they wake up, especially elderly patients. You didn't give them Versed. You give them a little dexmedetomidine. They're a little bit more relaxed, and they'll be a lot more alert after surgery. Next. So if you're going to give it over IV, do a 0.5 to 1 microgram per kilo over 10 minutes. I kind of went over how I do mine. I get 5 to 10 mics bolus. Well, in pre-op, and then I'll work another 10 to 20 mics in as we're going to the operating room and before induction. So typically, most patients will have 20 to 30 micrograms total on board before induction. And then when I run the maintenance dose that I run is 0.4 micrograms per kilogram per hour. The half-life is a lot shorter, as you see. It's 2.5 hours compared to 18 hours with clonidine. So your glutamate antagonist, your most popular one's going to be ketamine. That's going to prevent glutamate from activating NMDA receptors. Can be used to reverse opioid tolerance and opiate-induced hyperalgesia. Recent research shows efficacy in treating CPRS, PTSD, anxiety, and depression. So over a decade ago when I was in training, everybody frowned upon the use of ketamine in a patient with any type of mental disorder. And now the only patient I won't give it to is somebody with schizophrenia. I give it to people with depression, give it to people with bipolar disorder, rarely have any type of issues. I've actually had patients reach out to me via Facebook Messenger, since I live in a town of 3,500 people, Everybody kind of knows everybody where I live. And so they'll look me up on Facebook and tell me how better their depression has been after surgery, and they want to know what I gave them. So if I take care of a lot of veterans, I use ketamine, low-dose ketamine and dexmedetomidine with them. It really decreases the incidence of emergence delirium with that patient population also. So at induction, I used to give a 0.5 milligram per kilo. I'm probably more at what ASRA recommends now is about 0.3 milligrams per kilo. Because I'm running that maintenance dose at about 0.3 milligrams per kilogram per hour. So that's 5 mics per kilogram per minute. And it works very well. You can give more ketamine if needed. So if they have, as the case starts, if they have response surgical stimulation or something, I might give 5 mics of dexmedetomidine and 5 milligrams of ketamine and see how the patient does with that. I use lots and lots and lots of ketamine in my anesthetic. Almost every patient who has a general anesthetic, orthopedic surgery, something gets ketamine. We hardly have any type of issues impact you with postoperative hallucinations. It's me and 3 other nurses. So if I was messing up their PACU and making them work hard, they would be letting me know. And it's not an issue. I think it's because with the dexmedetomidine and the ketamine marry well together, and the dexmedetomidine might just decrease those postoperative hallucinations. Next. Nitrous oxide, which is an NMDA antagonist. It's not going to do much for you postoperative, but intraoperatively, it can help with pain management. But there's also been evidence showing that patients who get nitrous oxide intraoperatively actually have a decreased amount of chronic pain postoperatively. And that came out of a study where they're looking to see if nitrous oxide increased the risk of heart attacks. And secondary outcome, what they found was patients who got nitrous oxide actually had less incidence of chronic pain postoperatively than those that didn't get nitrous oxide. So a beneficial outcome that they weren't even looking for. So magnesium, as I said before, we kind of want to increase the extracellular concentration of magnesium because of that magnesium plug in the NMDA receptor. Magnesium by itself isn't really going to be that effective. Magnesium and ketamine need to be together. They're married together. So if you're going to give magnesium, make sure you're giving some ketamine with it. I used to bolus my magnesium with induction, but I found that that was the biggest offender of patients' blood pressure. If I gave just little boluses of magnesium, that's when I had blood pressure issues after induction. When I removed that, the vital signs were very stable post-induction. I wasn't having to treat a blood pressure immediately after my nerve blocks. So I just kind of run my mix, and it has magnesium in it. You're giving magnesium with ketamine together, and it's, most patients are going to get a milligram or a gram of mag with the mix if you infuse it all. If you want, I would just bolus that magnesium slowly, like maybe 100 to 200 milligrams at a time. So your gabapentinoids, presynaptic binding to the alpha-2 delta subunit of a voltage-gated calcium channel. They prevent the release of glutamate, norepi, substance P, and calcitonin gene related peptide. And your two gabapentinoids on the market right now in America are gabapentin and pregabalin. So gabapentin was first used as an anticonvulsant. It helps to decrease opioid use and decreases PONV, specifically for like GYN type surgeries. If you're going to give it 300 milligrams, if you give 600 to 1200, your patient's going to sleep. Personally, we stopped giving gabapentin in my practice. One of my astute PACU nurses realized that patients who got gabapentin and dexmedetomidine came out with soft blood pressures in recovery. They were great in the operating room. I didn't have any issues. But when we got into recovery and they didn't have any surgical stimulation, their blood pressures would just be so soft and we were having to treat them. And then she realized the patients who just they kept saying it was the dexmedetomidine, but then she realized the patients who got just dexmedetomidine didn't have that issue. So we stopped giving gabapentin. We didn't see any type of changes in our PACU pain scores omitting gabapentin. So I really don't use it. I think a better gabapentinoid, if you're going to use one, is going to be pregabalin, which would be the next one, Lyrica. The only thing, the difference between the big difference between the two, of why a lot of hospitals like to use gabapentin, is it's a lot cheaper than pregabalin or Lyrica. With pregabalin, you have a faster absorption and onset than gabapentin. The analgesia effects are similar to gabapentin, and we didn't have those blood pressure issues. We were just getting a lot of pushback from pharmacy because of the cost of it, and they kept saying that gabapentin was an equal substitution, but they weren't taking care of the patients in recovery. So we just kind of stopped using it altogether. I'll use gabapentin here and there for like GYN cases if a patient has strong PONV history or something like that. But I really try to stay away from gabapentin nowadays. So your different analgesics are going to be acetaminophen, esmolol, and Nubain. So acetaminophen, mechanism of action used to not be clearly understood. This is an old slide. It actually is, acetaminophen works on a CB1, cannabinoid type 1 receptor. It's a metabolite AM404, which activates a cannabinoid receptor. So for our whole life, all of us pretty much have been taking a cannabinoid medication for pain management. Some places have IV, some places only have PO. Just give either one of them before incision. All of my patients will get Tylenol in the pre-op arena. And then we typically give them a gram PO. I work for an HCA hospital, so they're not going to give me IV yet. Hopefully soon I'll be able to get that. It'd be good for, patients who are in longer cases where I can redose it, or those who I need to keep NPO. Esmolol as a pain medication, the thoughts is that it's inhibition of beta adrenal receptors altering a G protein activation, and that causes an inhibition of neurotransmitter release in the substantia gelatinosa neuron, so lamina 2. A neat thing to do you might want to try out is if you have a patient who's like LMA case, spontaneously breathing, and they start to have some surgical stimulation, give 30 to 50 milligrams of esmolol and see what happens to their respiratory rate. You'll be surprised that it actually decreases. So you're seeing the nociceptive action of esmolol. I really push for the use of esmolol if you really want to try OFA and you think the only thing that you need to give fentanyl for is induction. Just give 30 to 50 milligrams of esmolol on induction, and it'll blunt the sympathetic response to laryngoscopy. And there's initial dose, 0.5 to 1 milligram per kilo, and then if you wanted to do an infusion, run it at 5 to 15 mics per kilo per minute. I typically use, if I'm going to use it, 0.5 milligram per kilo bolus. Nubane is a full kappa agonist and partial mu antagonist. So it's not going to be very helpful for any of your patients who are on buprenorphine because that's a full kappa antagonist. But Nubane is about equal potent to morphine and quarter potency of Narcan. So if you give Nubane, you still can give Dilaudid to a patient. At induction, about 0.2 milligrams per kilo. I typically give 5 to 10 at induction. Females respond to Nubane a lot better than males, and there's a genetic disposition there. There's several studies highlighting that. So Nubane, very, very helpful for women, not so much for males. If you're going to give it to male, you might have to give more Nubane. Next slide. And so this is the McLottMix. So when I started doing it, or OFA, I was hand bolusing everything. And I kind of knew I wanted to give ketamine and magnesium together. I knew the importance of running a lidocaine infusion and giving dexmedetomidine. So after a couple of months of hand bolusing everything and having a lidocaine infusion, I just decided I'm going to put it all in one bag. That was a big old bag of lidocaine, and I slowly realized, like, well, I can just use 2% lidocaine out of the drawer and just add the ketamine, magnesium, and dexmedetomidine to that, and then just put it in a 50 ml syringe, and whatever volume's in there, everyone's drug concentrations are different. For me, my ketamine and magnesium are pretty concentrated. So, I have maybe a total volume of 13 mLs when I make up the medications, and then I just draw off the bag or get a bag of normal saline and draw off the 37 mLs of fluid I need to make a 50 ml syringe worth. Run it at 0.5 ml per kilo per hour. And I typically run it up until they start closing incision. If it's been a long case, you'll figure out how patients react to it. But usually when you're tipping up towards 3-4 hour long case, maybe turn it off, 30, 45 minutes before the anticipated end of the case. And you'll notice how quick the patients wake up. They're more alert, especially if you haven't given any Versed to your patients. It's just it seems to be a smooth anesthetic. Never really meant for my mix to become as popular as it has. It just it spread like wildfire, and I'm happy that people find it useful. That makes me feel good that I've contributed to our profession and to our patient outcomes. But that's it. I think I gotta. Yeah. Okay. So this is a typical general anesthetic induction of how I do it. Like I've told you, I give a little bit of dexmedetomidine in pre-op, work in a little bit as we go back, typically 20 to 30 mics total. As we're getting monitors hooked up, I'll give the Toradol, I'll start to pre-oxygenate them. Then I'll give a bolus of lidocaine, give the propofol, and then I like to give my ketamine after the propofol. You can see I'm not using a whole lot of propofol. I'm only, most patients, 1 milligram per kilo. If you, and that's ideal body weight. So I rarely give more than 90 milligrams to a patient for induction. Because if you've given dexmedetomidine, you've given ketamine, and now you're giving propofol, they're asleep. You can check lash reflex and it's gone within 30 minutes of 30 seconds of pushing that propofol. What's going to make them apneic is the rocuronium. Okay. If you give a big dose of propofol, 150, 200, and you give them dexmedetomidine and ketamine, you're going to be resuscitating that patient at the beginning of the case. You're going to have very soft BPs. So a lower dose of propofol than what you're used to, but once that lash reflex is gone, your patient's asleep. You don't need to make them apneic with propofol, and that's what I teach my students is let's get them sedated. Let's use those medications to get them to stage 3, and then we'll use the rocuronium to make them suitable for induction or for intubation purposes. But yeah, I give a lot less propofol than most people would. After they've gone to sleep, that's when I give the Decadron. Don't give 10 milligrams of Decadron as you're pre-oxygenating your patient, because they're going to respond to you. They're going to have some perineal burning. So give it after you've gone to sleep, but preferably before incision. These are just some case report, just some examples of using, this was a, hemodynamically, stable, but, low blood count. This is an emergent ectopic rupture I brought straight back from the emergency room. You can see I was hand bolusing stuff, I believe, at that time. And, she was nice and stable. I got, then I think there's one more record. And then this is a transverse colectomy that we did OFA, QL3 blocks. She took 4 milligrams of morphine that night, discharged post-operative day 2. Our elective colectomies have a length of stay less than 2 days now. They don't get any opiates intraoperatively. Very low. Post-operatively, bowel functions come back so fast. Our general surgeon, who came to us straight out of training, and he made us not block patients for 3 months because he needed to see what patients look like without nerve blocks, because he didn't know what they look like in his own practice out of school. And then he saw, and then he wanted his blocks back. All right, next slide. And then these are some websites you can go to. The Society for Opiate-Free Anesthesia, which was started by Tom Baribeau, who's a CRNA. Very good resources there, some protocols and stuff. And then after my mix became real popular and I was getting inundated with all types of questions from pharmacies and CRNAs messaging me and everything, I decided, well, let me put together a website, and on there you can find how to use the mix. I have a category on there for the dosage calculators, weight calculators, a breakdown of all the different types of medications you use in opiate-free anesthesia. Try to make it a one-stop shop for people who are interested in opiate-free anesthesia. So if you feel like you want to learn more about it, it's a good site to go to. And that concludes my presentation. Thanks for having me, y'all.
I really appreciate you sharing your knowledge with us and presenting to not only our sRNAs, but we got some CRNAs on here as well. Does anybody have any questions for Jason?
I do. Hi, Jason. My name's Aaron. I'm actually one of the new CRNAs. I recently graduated from UTC's program last summer. You mentioned about the ketamine. The only patient population that you don't use it in are the schizophrenics. What about patients who also have a history of seizures? I was trying to look up some articles, and they're kind of half say don't use it, half say it's okay, whether or not they're either on Keppra for their epilepsy or new onset seizures or what have you. My background is I was a flight nurse before I did anesthesia, and a part of our induction protocol for car accidents or traumatic brain injuries or whatnot, really regardless of what kind of head injury they had, it was 2 milligrams per kilo of ketamine with 2 per of succinylcholine, and then anywhere from 1 to 2 mics per kilo for the fentanyl. So in the EMS background that I had, they use ketamine a lot, and they don't really consider the whole brain bleed aspect of ketamine and what it does to the head. But now that I've gotten in the anesthesia world, I've noticed that a lot of the anesthesiologists, whether if we're doing a cranie or even if they have a history of seizures, they're very much against it. So I was just kind of wondering what your, I guess, experience has been with it.
Yeah, so I still use it. It hasn't, I haven't had any issues. Actually, ketamine is a second line treatment for status epilepticus. So they use ketamine in patients with, status epilepticus. It's a second line treatment. I haven't had any issues with it. If you're concerned about it, just wouldn't go overboard on it. But, if you keep your dosage less than, 50 milligrams, that's going to be less than a milligram per kilo, maybe only like a half a milligram per kilo total. You'll have analgesia from the ketamine. We're not looking for, like an induction profile with the ketamine. We're just looking for the analgesic properties of it. And that it's probably old dogma is why the anesthesiologists aren't using ketamine in patients with a seizure disorder.
Gotcha. Thank you.
Mm-hmm.
Do you have a case duration where you won't use the mix, you'll use the bolus dosing, or do you pretty much always go towards the infusion?
So if I know the surgeon's going to be if it's going to be a 30-minute surgery, then I'll just bolus. If I make up the mix so fast now that I'll make it up a lot of times. So I make up, my ketamine syringe is 5 milligrams per ml, 10 ml syringe. I have dexmedetomidine, which is a 10 mics per ml syringe. So really, when I make up my mix, I draw 10 mLs at 2%. My magnesium is 1 gram and 2 mLs. So I draw that up, and then I just squirt 3 cc's of the ketamine, or 6 cc's of the ketamine, and then 4 cc's of my Presidex, and just draw the fluid. So I can make up my mix in a matter of 30 seconds. So, but if you're learning about it, and it's going to take time, hand bolusing is just as good. If it's going to be, you have a surgeon who does a 15-minute gallbladder, it might not behoove you to run the mix. But, if it's going to be an hour plus case, I would run the infusion. But anything less than that, you might just want to try hand bolusing it.
Have you heard any surgeons complain about Toradol at the beginning of the case rather than just at the end?
Well, they always blame us if they can't get their bleeding under control. So really, if you give that small dose, you're not going to have the bleeding side effect profile. So one of the stories I like to tell is I had a surgeon when I first started at my hospital who told me never to give Toradol for a lap chole because it will cause bleeding. And I gave Toradol to every one of his lap choles for about 5 years. And on his last day, when everyone was saying bye and everything, I said, Dr. Robinson, can I tell you something? He said, yeah. He goes, I gave every one of your lap choles Toradol, and we never had a comeback bleed. And then he said, well, I don't expect any less from somebody from Detroit. So, but so personally, I don't think it causes that much of a bleeding issue. We don't have any bleeding issues. I have a very fresh surgeon, and she doesn't have any issues. So giving just that small dose up front, and then, if there were some bleeding issues, then just don't give the other 15, but it's not going to be 15 milligrams of Toradol that's causing a platelet issue 30 minutes into surgery. Any others?
What's
I've
the
actually-
longest case you've ran your mix on?
6-hour colectomy. And then I turned it off maybe, I don't know, 45 minutes before the end, and patient was pretty awake. My surgeons complain that they don't like giving a debriefing in the operating room. Because that's how alert some patients can be. If you haven't given them any opiate in Versed, you'll be very surprised on how alert a patient is after surgery. I get students from Western Carolina University, and that's the first thing they tell me is how surprised they are how awake their patients are in recovery. Like they just can't believe it. Like this doesn't make any sense. I'm like, well, that's what happens when you don't give them a bunch of opiates and benzodiazepines. That's going to make them sleep. The dexmedetomidine, which a lot of people are scared their patients are going to sleep. Well, they're sleeping because it's working on the locus coeruleus. So just stimulate them and they'll wake up.
So then if you have an issue where I say, start waking up too soon or before before closing, whatever, do you just cover with?
Yeah, they still got gas on. Like, I'm not going to titrate the gas, I'm not going to start waking them up until the surgeon's done. I at least let them get the fascia closed before I start waking them up. But no, they wake up pretty fast. I know a lot of people use this for spine surgeries, and I know those can go a lot longer than what I'm doing at a critical access hospital with general surgeries. But yeah, you can turn it off. The biggest, if people, it's funny. I never meant people to use my mix, but then when people have issues, they act like I forced it upon them, and so they'll message me complaining to me about something. And what I find is a lot of people run it at total body weight, and that's what's going to get you in trouble if you're going to have a somnolent patient in recovery, typically.
We did it on one. It was a long case. It was a Whipple. It ended up going for like 14 hours. And now we didn't do it. We did all the meds at the same rates, but not necessarily in the mix, just more for like a concentration sake. But then they ended up wanting to leave the patient intubated to take him up to the unit and let him wake up overnight because of how long it went. So my only is I didn't have a solid plan. My goal was, that hour, before waking up, and then just kind of hope for the best. I couldn't really find a lot as far as, for those long cases, when to stop it to have
I would
the
be
best
totally
wake up.
guessing on a 14-hour case to want to tell you to turn it off. But really, you'd be surprised on how fast, even after a long case, how some of these patients go. Now, you might want to, look at the ketamine, a case that long, after they've gotten, a total of maybe 150 of ketamine, probably turn that off. There, you're going to have good central sensitization inhibition after, their NMDA receptors are pretty much saturated probably by then.
And that's what we did. We only,
interesting.
once the second bag had infused in, we didn't hang any more. We just let it stay. So cool. Thank you very much.
You're welcome.
All right. Well, if nobody else has any questions, I guess we'll dismiss. Jason, we really do appreciate your time, and your presentation was awesome. So thank you for being with us today.
Thank you for having me. Sorry about the technical difficulties at the beginning.
No worries.
All right.
All right. Well,
If you
y'all,
guys have any questions, feel free to reach out to me through my website. The email address is there. I'm more than happy to help anybody out.
all right.
All right.
All right,
Thank you.
appreciate it. Y'all have a good night. Thank you.
Bye.
All right, bye.